Good morning and good evening wherever you are. This is Ellie from USC International Academy. Welcome to the series of USC graduate program event, which will help you to learn cutting-edge knowledge in different academic areas and inspire you to think beyond. Today's webinar is the 117th USC event. It's wonderful to see all of you can join our webinar today. Whether you are joining this webinar via Zoom or through our live stream platforms, your presence is always the greatest form of support for us. So I do hope you can enjoy our event today. Okay, now I'd like to spotlight today's topic and our guest speakers. This webinar is going to talk about storytelling in health communication by Dr. Deborah Fui-Yuen. Dr. Deborah is the Instructional Assistant Professor of Gerontology. Welcome, Dr. Deborah. And also welcome our old friends, May and Steven Stamm. May is the Director of International Student Initiatives and the Director of Information Technology. Steven is the Admission Counselor. They are all from USC Leonard Davios School of Gerontology. Welcome, May and Steven. Before starting the speech, dear audience, we will have 15 minutes to 20 minutes Q&A section after speech. So please feel free to leave your questions into the chat box at any time. We will try our best to get as many questions as we can. And kindly remind to our Zoom audience that this webinar will be recorded. So please mute yourself during the presentation for the good webinar quality. Thank you very much. And now I will pass it over to May first. Welcome, May.
谢谢 Ellie， 大家早上好欢迎你们今天来参加这个讲座。我的名字叫做 May Ing， 我的中文名字叫做吴燕梅。我是南加州大学老年学院的国际交流和资讯科技总监。
Dr. Ho has extensive experience working with older adults to navigate age-related changes and prepare for life transitions in the US, Singapore, and Hong Kong. Her dissertation research focused primarily on storytelling as a health communication tool among older adults. Dr. Ho is also certified as a guided autobiography instructor and pet loss and bereavement counselor. Her current research interest is health literacy, specifically in palliative care. Without further ado, Dr. Deborah Ho.
Thank you so much, Stephen. Thanks, May, Ellie, and Kiara for the invitation. I'm so sorry, despite me having a Chinese name, I am ashamed to admit it, but I do not speak Chinese. That said, I am very much proud of my Chinese heritage. Growing up in Malaysia with my Chinese family and whatnot. And it's just a great pleasure to be with you today. Unfortunately, I don't see any of you, but I hope you enjoy today's presentation. So the topic for today is storytelling and health communication. And specifically, I will be discussing improving palliative care knowledge among community-based older adults. This was part of my dissertation research and something that I continue to pursue in my free time nowadays. Oops, I didn't move. Okay, so let me do a quick introduction first. Who am I? I am, as I was introduced, I'm an instructional assistant professor currently serving at Leonard Davios School of Gerontology at the University of Southern California. Now, I come from a very varied background. I'm one of those who really enjoyed doing different things in life. So I first pursued my degree in mathematics at the University of Iowa. And when I decided I had used enough of my left brain, I wanted to kind of develop my right brain, I pursued my master's in digital storytelling in Ball State University. Subsequently, I returned home to Malaysia, where I'm from in Kuala Lumpur, and decided that it was time for me to serve the community, to give back. But I wasn't sure which segment of society to work with. So I did a little personality test, career test, talked to a lot of mentors and confidants, and suddenly I came across the word gerontology. And I was like, what is that about? little did I know it was the study of aging, working with older adults. And it dawned on me that throughout the course of my life, I mean, whether I was in Iowa, whether I was in Ball State University, whenever I left a place, the friends that I kept close to my heart were the older people. I did have friends my age, but a lot of times it was the older adults who really, really built or fostered this very strong bond and relationship with me. And I stayed in touch with them. So when I came across the word gerontology, I decided, okay, maybe I'll pursue a PhD in gerontology. Yet that was going to be a commitment of anywhere from 4 to 6 years of my life. And by the time I was a little bit older, so I looked for a program that was a little bit shorter in order to ensure this was something I wanted to commit the rest of my life to. Lo and behold, I came across this program at the University of Hong Kong. I spent 1 year there pursuing the Master of Social Science, specifically in gerontology, and I absolutely loved my time there. The game changer for me, or the thing that really made me realize how much I loved working with older adults, was volunteering at the one care and attention home in Hong Kong that was catering to English-speaking residents. And every week I would take 2 buses all the way from Hong Kong Island to the Kowloon side, just to sit and chat, or just to play cards with 4 specific older adults. And that really changed my life. Every time I left the place, I left very fulfilled, very happy, very satisfied. And that's when I decided, okay, I'm going to pursue my PhD in gerontology at the University of Southern California, because why not go to the #1 school for gerontology as a subject, and in a city as vibrant as Los Angeles, which provides very, very fertile ground for research and exposure to all things related to aging. Specifically, my research focused on end of life, health communication, and I have dabbled in some studies also related to end of life in spirituality. Some of my secondary interests include age discrimination. My particular focus is on self-ageism, so age discrimination directed to yourself, because I think it is a very debilitating mentality to have. And I'm also very concerned about income security in older age, because having lived in a retirement community here in Los Angeles, I have witnessed firsthand the effects of having sufficient income security versus having inadequate income security in older age, and its trickle-down effects. So all that aside, we move on to the crux of the matter today. And so we're talking about palliative care today. Okay? To begin with, let me define what palliative care is for you. In the US, palliative care is known as specialized medical care that aims to provide comfort and supportive care to seriously ill patients. The key word here is seriously ill patients, not dying patients. Okay? But irrespective of age and at any stage of their disease trajectory. Basically, you can be a child, you can be a middle-aged adult, you can be a young adult, you can be an older adult. It doesn't matter how old you are. And it doesn't matter at what stage of illness you have. If it is a serious illness, say heart disease or lung disease or cancer, if it is early stage or late stage of that serious illness, you can qualify for palliative care in the US, okay? Now, in the past, many people have studied the effectiveness of palliative care. And we found across many studies, across many years, palliative care is effective in managing your pain and symptoms. So you have improved quality of life when you have less pain, or at least are able to manage your pain, and if you're able to manage your symptoms. Further to that, In America, at least, many people say they wish to die at home versus dying in the hospital or a medical institution of some sort. And with palliative care, this provides a seamless path into hospice care and hence enabling them to fulfill their wishes to die at home. Subsequently, when patients are receiving palliative care, it is not uncommon for them to report greater satisfaction with their care or the care they received. And when the patient is happy, if you've ever been a caregiver in your life, or even if you just watched other people giving care, when the patient is happy, it is not unusual for the caregiver to be happy, because when the patient is struggling, is suffering, it creates a certain burden on the caregiver. So when the patient is comfortable, when the patient is happy, when the patient is free from pain, the caregiver is given some kind of relief from their role as well. In addition to that, many patients who are receiving palliative care report lower levels of anxiety and lower levels of depressive symptoms, hence leading to their increased quality of life. Right? Because when you're not anxious, when you're not depressed, obviously, you're more inclined to participate in school, in any activity that you wish to pursue. Okay? Furthermore, with palliative care, many studies have also shown that it results in a slight decrease in the cost of care for many, many reasons. In America especially, one of the biggest costs of care is when, let's just say you had, like my late father, he had cancer, and sometimes in the middle of the night, he may wake up and he feels very uncomfortable, maybe difficult to breathe. With access to certain palliative care, you actually are able to, say, contact a nurse over the phone, very often 24/7. And, they may be able to propose or to recommend certain things that you can do at home, certain modifications at home in order for the patient to be comfortable. If you didn't have access to that facility or that amenity, you will more than likely take them to the emergency room. And in America, at least, any visit to the emergency room results in higher cost of care. So with palliative care, you have certain access that is unique to palliative care, which also then lends itself to lower costs of care. Now, the growth in the US in terms of palliative care programs, it's 2023 now, so the growth in the last 10, 15 years has been remarkable. Now you can find palliative care in many large medical centers, in outpatient clinics, also cancer clinics, home care agencies, and community-based hospices. So one, we know that palliative care is effective in many, many ways for both patient and caregiver or the family members. And two, we know that there are many places that offer this service of palliative care. And yet we have this problem where consumer awareness about palliative care remains low. And when I say consumer awareness, it's people like you and me who may need to access palliative healthcare, but we don't know that there is this other additional layer of support called palliative care that we may access. In fact, studies have shown since 2011, right here, this was published by the Center to Advance Palliative Care, they found that 70% of the people they surveyed did not know anything about palliative care. They were not at all knowledgeable about palliative care. Then you move on to the following year, a study conducted by the California Healthcare Foundation, a separate entity, also found that in terms of whether or not people have heard the term palliative care, only 17% of those surveyed actually had heard of palliative care. Contrast that with other things such as hospice care and do not resuscitate orders. Only 17% had heard of palliative care. We haven't even talked about whether they knew what it was. Okay? Which brings me to the third study published more recently in 2019, just before the pandemic. This is a nationally representative survey, meaning the sample mimics the population composition of the United States. And what we found was there is overall low awareness about palliative care. 66% don't know anything at all about palliative care. 21% say they know a little bit, but 13% claim that they know and can explain what palliative care is. So for this group of people who think they know at least a little bit about palliative care, they were asked a follow-up question to name 3 features of palliative care. Turns out, just focusing on those who said they know and can explain what palliative care is, almost half of them actually didn't know what palliative care really is. They answered at least one of the 3 follow-up questions wrongly. So that's where we're at. Okay, we know it's effective. We know it's available to large segments of society, especially in urban areas or bigger cities. Yet consumers just don't know that they have access to these services, these additional services. In the past, different approaches have been taken to educate the public. So if you're admitted, then they will refer you to maybe a palliative care physician. Fundamentally, most of the time, we rely on our physicians to tell us about the services that are available to us. Unfortunately, as other studies have shown, the physicians themselves fall in the category of knowing very little or knowing nothing at all. Very few physicians actually know what palliative care is and can accurately answer the questions about palliative care. Further to that, a lot of public education, even if it's in video form, it's very impersonal. Okay, you don't really get to know the people who are featured in these videos. And the problem with a lot of existing literature educating the public about palliative care is that we never address the common misconception, because more often than not, people confuse palliative care with hospice care. And hospice care is catering specifically to people who are in the end of life stage. Palliative care, again, is accessible to anyone at any age and at any stage of a serious illness. Okay? So, most times as well, this top-down approach has not been as effective as hoped. Okay? Anything that is available online, be it through YouTube videos and whatnot, generally are not inclusive. In the US, what that means is, for one, the level of language that they use is at a very higher level, meaning someone who maybe has studied to 10th grade, which is, I don't remember how old that is. Maybe Stephen or May can clarify that. But if I remember correctly, it's about like 11 or 12 years old, I think, or maybe a little bit older. So whatever it is the most sophisticated level of language. Very often as well, YouTube videos especially, and this is based on a study that my colleagues conducted, most of the time you only see a certain group of people. In this instance, it was mostly white Caucasian people, people who identified as white. And very rarely would you actually see patients who talk about palliative care. It's always a doctor, a nurse, or some other healthcare professional, which may explain why the language they use is also a higher level, because that is how they are used to speaking about palliative care. Okay? So these are all problems. And ultimately, what was the most bothersome thing was that low consumer awareness meant that people were not able to receive palliative care that could potentially benefit them. that could provide the extra layer of support, that could provide a certain level of relief to them as they journey in their serious illness. So the question that I asked was, how do we narrow this gap between the services we have available and levels of awareness about these services? So going back to my education, as I mentioned earlier, I was also trained in digital storytelling. And that is one of my great loves, personal storytelling. I love listening to people's stories. I love writing stories. And I'm not talking fictional stories. They're true stories about myself. And I've done that before, be it writing or live storytelling. So performing for others, telling my actual life story. So it was only natural to me that in order to narrow this gap, we had to take advantage of this very powerful tool. And hence, I decided, okay, maybe I need to explore personal stories. So, of course, being a researcher, everything is theoretically based, everything is evidence-based. And in the past, many such interventions have employed these two theories, the social learning theory and the theory of reasoned action. Very simply, the social learning theory says that we as human beings, we conduct ourselves or we behave in ways that are based on copying other people's behaviors. I mean, you think about a little child, right? When they are 1 year old, 2 years old, 3 years old, the way they learn is by watching us, the adults surrounding them, and then they copy us. And that's how they learn to behave, that's how they learn to speak, that's how they learn about life and how to live life, through the people around them, their environment. Then the theory of reasoned action said, when you are exposed to a certain social norm, when you observe people doing things a certain way, in order to fit in, you also are more than likely to adopt similar behaviors, okay? Which makes a lot of sense, right? If everyone is walking straight, you don't want to be running around zigzagging, that kind of thing. You're probably going to follow the line and walk straight. Okay. Further to that, these have been used in other behavioral interventions, for example, in HIV education, in programs to stop people from smoking, as well as other addictive behaviors. Further to that, I've always strongly felt we need to move with the time. We no longer are, limited. Now we live in a world that is boundaryless. We're not restricted to a certain way or a certain thinking only. We have access to a lot of information, such as this webinar. I mean, it's pretty wild to me to think that here I am in Los Angeles, but there all of you are in different parts of Asia. So likewise, we need to move with the times in the ways we approach health education or health communication. Again, blending from my experience in digital storytelling, I was keen to maximize the potential of digital media. And again, because I love storytelling, I strongly feel that oral communication through storytelling helps, one, people retain information, two, appeals to our emotions, and not to mention our logic, the way we think, three, it is suitable for all types of learners, and four, it encourages action. So that is the power of oral communication through storytelling. And most importantly, I have always placed high emphasis on first-person storytelling because we are each unique individuals and we each have a great story to tell. We're just not necessarily used to doing so or encouraged to do so, but we're all very, very special in that sense. And not to mention, when we tell our stories, it evokes emotions within us, making it authentic, making it appealing. And as human beings, when you see someone sharing their stories with you, and if you are moved by it, it's easier to relate to them because you are also human, right? So I love storytelling for all these reasons. Therefore, we crafted or we designed our approach. For one, we went out to conduct interviews with patients in their homes. We had a semi-structured interview protocol. So everyone was asked the same set of questions. And then we videotaped and we transcribed, meaning we basically took whatever they said word for word and typed it out. So whatever they said, whether it was grammatically correct or wrong, whether it was a slang or whether it was, some other unique phrase to a specific culture, we didn't try to change anything. We preserved it as it is because that is preserving the authenticity of the storyteller or the patient, the individual. And we also asked some questions that enabled them to provide personal information. So nothing too personal, but just basic information about them. And the questions also sought to enable the patients to convey accurate and identifiable experiences they may have had with palliative care. So the video element, when we had done all of that, interview, transcribe, and whatnot, then we started to edit the videos. And we tried to keep it standard in the sense that we included things like personal information that they were willing to share. So things like name, age, maybe some information about their family. We also talked about their illness history or the progression of their diseases. They discussed their initial response to palliative care, like when they first heard about it, be it their thoughts, their beliefs, their misconceptions. Then we encouraged them to talk about their experiences with palliative care, which is, by the way, something that is provided for by a team of people. It's not just doctors, it's not just nurses. Most times, palliative care, an evidence-based model of palliative care, means that a team of people are serving you. They include a board-certified palliative care physician, a nurse practitioner, very often a social worker, and sometimes some other therapists, like maybe a respiratory therapist, a therapist who teaches you how to manage lung issues, especially if you have trouble breathing. It could include occupational therapists or even physical therapists. And sometimes, if the patient wants, access to a chaplain or spiritual counselor. So someone that you can discuss things that are related to, anything about your disease or anything separate from your disease. Okay. Patients were also encouraged to share with us the outcomes resulting from the receipt of palliative care. So how they felt or what benefits they felt they received from receiving palliative care. The study procedure then, once we collected the role model stories, we had to test whether these stories were effective, whether they could actually improve palliative care knowledge among community-based older adults. And when I say older adults, I mean adults age 50 and older. Okay? So what we did was a pre-test, post-test study design. We first did the pre-test. So we had them answer a set of questions. So we had the palliative care knowledge scale, which is a 13-item scale. So it's 13 questions about palliative care. We had questions on whether or not they intended to enroll in palliative care services. And then we had basic socio-demographic questions like age, race, ethnicity, gender, marital status. So we had them do that through the pre-test. Following that, we showed them the 3 role model stories. Altogether, they were about 12 minutes long. That's about it. Okay. Subsequently, we had them do a post-test, which was the same thing, basically answering these same questions, the 13-item scale, questions whether or not they wish to enroll in palliative care services. And of course, this one we didn't ask them again, simply because that wouldn't have changed over the 12 minutes. Okay. So what we found was very fascinating to me. simply because we had about 161 adults age 50 and older. I think the oldest one, if I remember correctly, was 101 years old. Yes. So they range in age from 51 years old to 101 years old. So it's pretty cool because it's a 50-year difference, right, between the two. The mean age was 76.3, okay, with a standard deviation of about 12 years. Many of them were fairly educated, okay, they at least had high school education, so that was the lowest. 72% were female, and they comprised of different race or ethnic backgrounds, Black African American, Asian, Caucasian white, Hispanic, and other races. Okay, so I like to think that this sample was fairly diverse in that sense, even though they were still fairly highly educated. I think that this has a lot to do with actually where we were conducting the study, which is Los Angeles, and we live in areas where a lot of people we recruited were also living around institutions of education, and so it's not unusual for these types of populations or societies to be a little bit more educated. Interestingly enough, when we did our analysis, we found that mean total knowledge scores improved and intentions to enroll in palliative care increased across the board. So what does that mean? If you look at this chart, the change in total knowledge scores, so this is before we showed them the videos. When they answered the question, so the maximum number of questions was 13. That was the total score, okay, 0 to 13. Now, on average, people scored 4.64 questions correctly. Okay, on average, they got about 4.6 questions correct. So we showed them the videos over 12 minutes, and then we tested them again, and look at the jump in scores, the improvement in knowledge scores. They jumped from 4.6 average to a 9.99 average, which is a really remarkable jump after only 12 minutes, okay? And not to mention the standard deviation, so the differences or the variance between from the mean was much larger before, and this is much narrower. So most people got these type the scores within this range. Okay? A couple of outliers here, but it was probably in part because some of them they would do the first test and then they would be too tired to finish the second test. And I know this was true for the 101-year-old. It was hard to forget her. And she, by the time we had watched the videos, she was really too tired to actually complete the second survey. So those are some of the reasons why we have outliers like that. But basically that shift, that jump from 4.6 to 9.99 was a statistically significant increase or improvement in knowledge scores. Further to that, before the intervention, before the videos, only 36% of people said they would consider enrolling themselves in palliative care, and 37.3% said that they would consider enrolling a family member who is seriously ill in palliative care. After watching the videos, though, both groups of people increased significantly. Okay, so for themselves, 36% initially jumped to 73% of people who said, yes, I would consider enrolling myself in palliative care if I needed it. While for their family members, we saw an increase from 37% to 78% of people who would consider enrolling their family member in palliative care. And both are statistically significant. To me, the most important finding is that authenticity drives greater change in score. And what that means is we included a question asking the participants, the study participants, whether or not they believe the patient the video that they were watching was authentic or not, whether the person who was telling the stories was real or not, a real patient or not. And if you look at it right here for this question, the association between their belief or their trust that the role model was a real patient was very, very strongly associated or correlated with a higher change in score. So put another way, if they believe that patient was real, not someone who was just acting and telling a story, more than likely their scores improved even more than other people who didn't think it was a real patient in the video. Okay. So all that to say, the key takeaway for me was that personal stories by role models, okay, when you use real stories to tell people, to inform people about a particular service, and in this case it's palliative care, it has this ability to aid people's knowledge acquisition, their ability to learn about something, their ability to understand something that they previously did not know about nor understood. Okay? And this seems to work across the board. It doesn't matter what your background is in terms of race or ethnic background. While this study specifically doesn't show it, we did replicate this study with a Spanish-speaking group of people, and we found similar improvements in knowledge. Okay? So, I mean, I think any one of us, if we were to ask ourselves, do we love listening to stories, especially true stories? I think all of us would say yes, because they are engaging in a way that not many other fictional stories are able to engage with. Granted, while that was a key finding in this study, I admit that our sample or our group of participants, they're more urban, meaning they live in a bigger city, so they're a little bit more, the exposure they have in life is a little bit different. And generally, admittedly, they were more highly educated. But yes, even though in my study, we excluded non-English speaking participants, as I said earlier, we did the same study with a Spanish-speaking group of people using Spanish patient stories, and we found very, very similar outcomes or similar results. Okay. In summary, what we found was that once people who did not know what palliative care is or did not understand it, once they heard about it and they understood what kind of services they have access to through palliative care, people want palliative care. And therefore, I would say role model stories, meaning patient stories, authentic, true patient stories, is an effective way of increasing awareness or knowledge about palliative care. And more importantly, when you go digital, it becomes borderless, right? It's a lot less expenditure. You don't have to print anything. You don't have to make sure you send it out to anyone. You don't have to paste any flyers. You just send out something like a QR code or something like that, and people can access it nowadays, since many layers of society at least have access to a smartphone with Wi-Fi services. So ultimately, I don't know if we have time. Ellie, maybe you can tell me. I have one example of a story that we did. It's about 3-4 minutes long. Do we have time for that? Okay. So I will play this story. Thanks, Ellie. So this is one of the many stories that we produced. If you want to watch it again, or you want to watch any other stories, you're free to scan this QR code. It should take you to my former advisor's lab page, where we have a collection of stories, be it patients, caregivers, in English and in Spanish. So let me just quickly play this, and let me know if there's no sound. It should be sharing with sound.
My name's Ted Belaska. I was born in Detroit, Michigan, and my family all lives there in Michigan. I live in California. I used to be in construction. I was a carpenter, a journeyman carpenter, building custom homes up there in Serrano, in El Dorado Hills there. And Really liked that. It was good work and had plenty of it. Just can't do any more of it now. It just hurt too bad anymore, so.
Ted was diagnosed with bone cancer and liver cancer 3 years ago.
Before I found out that I had it, it's been 3 years. It's progressed along pretty good. It was stage 4 when we found out that I had it. Well, yeah, I'm not really gonna get fixed. We're just she's trying all the options and stuff like that. I'm on that Optivo for the chemo treatment right now.
Palliative care is specialized medical care for people with serious illness. Palliative care provides an extra layer of support in addition to regular health care.
The first time that I ever heard of palliative care, I heard of it from my doctor. And personally, what I thought it was going to be is just like you said, I just figured it was going to be just a bunch of old nurses and, you know, feed me as in a bed or something like that. But it's not like that at all. They're kind of like above that, so they helped me out quite a bit, actually. I was able to see them more often. Well, they were able to come here more often than me to see the doctor. And I would be able to have more time to explain to them and let them know what's happening, and they could talk to the doctor. They really helped me manage my pain. Pain was the biggest thing that I had that needed to be taken care of. And as soon as we got that all taken care of, I was able to take a breath and relax, and it's all good now. I'm glad they came around. When they were here today, they were making sure that my prescriptions were all okay down at the pharmacy, and my other nurse was talking to my insurance company about a ride to my doctor's appointment and stuff. There was papers that needed to be faxed over, and she took care of all that. And it's just like stuff that I don't have to worry. They don't want me to worry about nothing.
Palliative care provides relief from the symptoms and stress of a serious illness through medical, emotional, and spiritual support. The goal is to improve quality of life for both the patient and the family.
I'm going to go back and visit my dad for the summer. It's going to have to be in between the treatment if we're having them every 2 weeks. And my dad really doesn't like it when it's only 2 weeks. It's too short. But I'm going fishing. I'm getting back on those Great Lakes and hitting the fishing again, at least once. I wasn't able to do it last year. I was too sick. This year I want to. Well, the last time I was there, me and my dad, we went to Lake Erie, went to Canada and jumped on Lake Erie, and boy, we just had a blast out there.
Alrighty, and that's the end of that. Before I close out, I just want to record my appreciation to my principal investigator and my mentor during my PhD studies, Dr. Susan Anguidanos, our co-investigator Annie Rahman, and my research assistants in this project, Kayla Johari and Art Bibukarut. Also, a heartfelt thanks to our generous funders who helped to support our process, the Heart to Heart Hospice Foundation and the ALM Foundation. So thank you very much to Ellie for this invitation, to May and Stephen for making this happen. I thoroughly enjoyed myself, so I'm open to any questions you may have.
Yes. Thank you, Dr. Deborah. Thank you for your kind and detailed descriptions. And they also left so many questions for this topic. So we will start with the first one. So
sure.
The first question is, so for those patients who are taken palliative care, the only purpose is to improve their quality of life? Thank you.
Okay, so in a way that is putting it very simply, isn't it? It's when you say just to improve quality of life. The thing is, quality of life is multi-layered. For different people, that may mean very different things. For, say, someone who is older, say, someone who is a grandfather, his idea of quality of life may be to live long enough to watch his grandson or granddaughter graduate, say in the next few months, you know. So the idea of quality of life is very different from individual to individual. And the first thing a trained palliative care physician usually asks the patient is, what is your goal in life? So what is your goal in life? What do you want to achieve? Now that you know you have this serious illness, you know you have this limitation in terms of your lifespan, what is it that you want to do in this remaining time you have? And so the doctor, the nurses, the entire palliative care team works with the patient and the patient's family member in order to try and reach that goal together. So it's not just quality of life, it's what the patient wants. It's how the patient defines quality of life. And that is different from individual to individual.
Thank you. And second question is, and the palliative care must be taken in the hospital, not at home, or there are some agents offer this service? Thank you.
That is a great question. When I was watching the video, I realized I didn't mention that. So thank you so much to whomever asked that question. So in the US, as I mentioned earlier, it's grown in, there's inpatient palliative care and hospice agencies and whatnot. So while inpatient palliative care in the hospital, it is more prevalent. However, in certain parts of the country, and Los Angeles, California is one of them, home-based palliative care is very, very prevalent. All our patients whom we interviewed are receiving home-based palliative care. So like Mr. Ted Velasquez, whom we just watched, he would actually have the nurses and the doctors from his palliative care team visit him in his home. And that is very useful because sometimes there are things that patients may struggle with when they are seriously ill that you don't think of or don't notice when you see them in a medical setting. If you actually scan the QR code earlier and you look through some of the other videos, at least two of them mentioned about how when they live in their houses, every week you have to take your trash bin out to the street for trash collection. Now, when you're seriously ill, that can be very difficult to do because it's heavy, you are weak, you may not have the energy or you may not even really be able to bring yourself to go beyond your house boundary, for example, because you're just very, very sick. So when the social worker, for example, visits their home and the social worker notices that they have their problem, these social workers have actually helped to contact the city, whichever department provides these services, and made arrangements so that these patients didn't have to push their trash bins out to the streets anymore. They could just like set it outside by the side of the homes, and then the people who would come and collect their trash would go into their homes, into their home area, the boundaries, to remove their trash for them. So in that sense, I think it's a growing field, home-based palliative care. It's slowly growing. It's increasingly common in California, but it really depends on where you are. Yes, in large parts of America, it probably is still provided mostly in the hospital. But in the state of California, for example, a lot of people actually receive home-based palliative care.
Thank you. And I can see some audience can also remind their own experiences that someone also said her or his aunt chose palliative care during her final days. So I think this also is very meaningful lecture to these students. And
thank you for sharing.
And another question is, could professor speak in Mandarin? And also another question is, what's the difference difference between the palliative care and the hospice? And is this the time of the rest of the life? Thank you.
Okay. I will address the I'll address the elephant in the room first. Yeah, despite me being of Chinese descent and loving the Chinese culture like crazy, and being as traditional as I can be within reason, I unfortunately do not speak any Chinese. I grew up in a household where my father spoke Cantonese because my paternal grandmother, so my father's mother, was Cantonese, and my father's father's father, so my grandfather was Hakka, is what we call it. I'm not sure if that's the right word in Chinese, but that's what we call them. And unfortunately, for some reason, everyone in my family, even my grandmother, would speak to us in English or our local language when I was growing up. So I never really picked up the language. I understand Cantonese a little bit because I love watching TVB series. So that's my exposure to Chinese. But I love watching Chinese series. It's been a while, yet my favorite Mandarin series, I guess, is, and forgive me if I'm pronouncing this wrongly, but I was in love with the series called Fu Fu Jing Xin. I think that it's old. I'm old, so I don't know if the younger people are familiar with it, but it's a really, really great Mandarin series that I followed. Okay, but on to, I guess, the more important question here in relation to palliative care. Palliative care, hospice care. That this is a great question to ask because this is one of the biggest barriers or the biggest challenges that we as palliative care researchers have had in the last, 10, 20, maybe even 30 years, because everyone thinks they are the same thing. Thank you to those who shared that you had positive experiences with palliative care in your family or for your family members, because it provided certain relief, I'm guessing, for you and your family. But you also mentioned that it was something that they received towards the end of their life. Now, if you do it correctly, in America, that is, palliative care is something that you can start receiving very much earlier on. Hospice care in America is really only for people who generally are said to have 6 months or less to live. Let me give you a very simple, a very personal example. In April 2012, I had just returned home from the US after finishing my graduate studies. And 1 month later, my father was diagnosed with cancer. Now, at the time, I didn't know I had not heard of palliative care. I hadn't heard of hospice care. But when my father was diagnosed, he made an appointment with an oncologist to treat his cancer. His cancer started in the nose, okay, in the back of the nose. So when he made an appointment with the oncologist, it's very typical for Asian families to all go to the hospital together. It's not just the patient, right? It's like the patient and then the spouse, husband or wife, and then the children will go if they can, at least one person, if not all of them. So same thing, we did the same thing. We went with my father, and it was very interesting to observe the different doors. So that was like the oncology ward where all the oncologist clinics were. And on each of the doors, of course, you have all the credentials, right? So so and so qualified in oncology from this university, so all of the doors had that information, except for my father's oncologist. Her name is Dr. Fu. And then at the end of her name, of course, she had all her medical degrees, including oncology certification, but she also had a certificate in radiology, and she had a certificate in palliative care. So to me, I was like, okay, maybe she just has a lot of degrees or a lot of certificates. She wants to show off, whatever, as long as she takes good care of my father. But that certification in palliative care made a major difference in the way she approached my father's treatment and care. Because every time she was prescribing something, her first focus, or her primary focus, was his quality of life. The first time she gave him the first chemo drug, my father was actually pretty good, pretty fine. But the problem is his cancer had spread from the nose to his lymph nodes in the neck. And as a result, he needed to go for radiotherapy on his neck. Now, if anyone has had a relative who's gone through radiation, you will know that after many rounds of radiation, the skin may look burned. In some instances, it will literally look black. And I've seen people with scars like that after they complete radiation. Because even though it is short amounts of radiation each time, whenever my father went, it was only for like 5 minutes each time. But we went for more than 30 days of this radiation. Every day, Monday to Friday, I would take him to the doctor, and then I'd wait outside for him. He would go in for a few minutes, get his radiation treatment, and then we'd go home. So, and then, of course, every few weeks, he would have to go for chemotherapy. Okay? Now, if anyone has been to chemotherapy, you would know it's not like a 5-minute thing. It is at least half a day long. So sometimes when I had time, because at the time I had just come home, I wasn't working yet, I would actually go to the hospital with my father, and he would purposely go early so that he would get a bed so that he could lie down. If you were late, no more beds, you would have to sit down on a chair. So he would go early to get a bed, and I would be so sleepy, I would get in bed with him. I would lie down next to him, and he would do his thing, and I would just like chit chat on that. So when you're there for so many hours, you're gonna talk to the people next to you. And in Malaysia, this nasopharyngeal cancer is very common, especially among people of Chinese descent. So we will talk to our neighbors, and they have different oncologists. So we compared the experiences between the other oncologists and my father's oncologist. My father did not suffer very much at all compared with the others. Everyone else complained about the radiation treatment because one of the side effects is you lose your saliva glands. You lose the ability to produce saliva. And when you don't have a saliva, it's amazing what other problems you can have, like fungal infections in the neck. You cannot chew, you cannot eat properly. So many other things that happen. But my father never really suffered any of these things because his oncologist was trained in palliative care. And so she prescribed things to prevent him from suffering other side effects. Without the saliva production, he used a special toothpaste. He used a special mouthwash so that he would reduce risk of fungal infections in his throat. She told us what to cook, special things like in different stages of his disease. Very common before he went for chemo, she recommended the boil red dates, Hongzhou. I'm not sure how you say it in Mandarin, but red dates, we would boil that for him to help boost his blood count. And then after radiation, because radiation is very hot on the body, chemotherapy is very hot, as in traditional Chinese medicine, right? All very hot on the body. So she recommended immediately after chemo that day, he should drink a fresh coconut, and not in one of those boxes, but she recommended we buy an actual coconut to drink because Chinese say coconuts are very cooling. And we did all that, and my father lived his best life after he was diagnosed with cancer. Even though he was going through all his treatment, he was actually able to really enjoy life. He was hardly at home. He was always out with his friends, except maybe 3 or 4 days after his chemotherapy, because he would be very tired. So he would stay at home. But otherwise, he was enjoying life to the maximum. And really, I credit that to his doctor, who was also trained in palliative care, because her major concern was always his quality of life. Was he going to be able to continue enjoying and doing the things that he loves doing, or will he be suffering and staying at home? Even when she had to prescribe other chemo drugs because the cancer came back twice, By the third time, she was concerned about prescribing that particular chemo drug because one of the side effects was his hair would fall. But thankfully, my father was, a real trooper. So as soon as his hair started falling, he just shaved everything off. And so the partnership between him and his oncologist was trained in palliative care was tremendous, was perfect for both of them. But palliative care, in his case, he started receiving palliative care informally from the very beginning, from the time he was first diagnosed. And that is the beauty of palliative care. You can receive it as early as whatever stage 1, stage 0 cancer, for example, or later if you're diagnosed later. Unlike hospice is only for people who probably don't have much hope, whose medical treatment cannot improve your quality of life, and certainly it's unable to treat you or to cure you any further. So I hope that answers the question, even though a very long-winded way of putting it.
Thank you. And our another question is, in
Sure.
general, what kind of institutions or organizations can provide this kind of service? Thank you.
Oh, okay. Great question as well. So it really depends on the state, but in California, one, medical centers may offer this service, so that would most likely be inpatient palliative care. We're trying to promote the growth of outpatient palliative care or primary care or palliative care at primary care level, meaning any primary care physician. I don't know about East Asia, but in Malaysia, the equivalent is general practitioner. So general doctors that you would visit. We're trying to promote expansion in that area. But in many parts of California as well, palliative care is very often provided for by hospice agencies as well, because they already have that team set up. The only difference is what stage of your disease trajectory you are on. And the approach is very similar. It's just that for one, you are trying to promote life, and the other one, you're trying to promote what we call good death, so to speak, so that the main thing is you don't suffer from excessive pain, and you are able to manage your symptoms. So many different institutions may offer it, basically.
Thank you. And next question is, how about use AI into this storytelling? It will release labor work and more efficient, right? Thank you.
That is the golden question, isn't it? Yes, I agree. It would actually lessen a lot of burden. But I think one thing we cannot deny is that we are human beings and we crave human connection. I think one of the things from our experience during COVID, and everything was remote, all of us could only communicate over the phone or over the computer. In the beginning, it was really nice, right? It was great, especially for me. I was very lazy to go out and stuff. So it's like, oh yes, I just turn on my computer and I'm connected to however many people. If I had a class at 9 o'clock in the morning, I can wake up at 8:45 and I'm on time, and I'm beautiful there because all you see is my face. Whatever I'm wearing below, it doesn't matter, right? But ultimately, we are human and we crave this human connection. And artificial intelligence cannot replace that. It can be a substitute. It can make life convenient, easier in a way, but it will never ever replace the value of being with another person. In my culture, for example, one of the things we're very used to is touching, and I'm not saying inappropriately. I mean, like when I talk to people, I like to touch them on their shoulder. It's just something that comes very naturally because it's my way of showing affection without being indecent, of course. So in that sense, AI cannot substitute these things. It just cannot. And ultimately, artificial intelligence may give you the facts. It will never be able to truly give you the emotion. And human beings are emotional creatures. And I thank God for that, because otherwise, life would be so dull, right? Without emotion. So, but I'm not dismissing AI. It may be able to help us improve or make things more efficient, that process more efficient, but it will never, ever replace completely being human.
Thank you. And next question is, actually the one who really need it may not really know about this kind of service. So, and don't know how to reach out to this kind of service. So how can we promote it better? Thank you.
That is the $1 million question. And that is something that I do not have the answer to, honestly. At most, I have this tool, which is very easy to spread, to disseminate. I mean, you just send a link or you send a QR code and anyone can share it, right? But ultimately, there is always going to be layers of society that we will miss. It's just a fact of life for the most part. So we've tried to educate doctors, but sometimes doctors have their own personal biases or their personal limitations that prevent them from even talking about these things with their patients. So at most, I would rely on word of mouth, but I really don't have that answer for you. We're still in very early stages of that. People, I mean, my advisor, for example, has been doing research on palliative care for more than 15 years now, maybe even 20 years. And she doesn't have the answer either. So I'm sorry, that is one question I cannot answer. But hopefully in the future, we will find an answer to that question. You can do us a favor by sharing the information with others, though.
Thank you. And next question is, I think this audience is very interested in the course that Dr. Deborah is currently teaching in USC. Can you just say about it? Thank you.
Oh, sure. Okay, cool. So I teach several courses at USC. I am housed in the Leonard Davis School of Gerontology. I like to think it's the best best department in all of USC because we're smaller and we're very, very much like family. I mean, I don't really see May or Steven very much, for example, but when I do see them, it's just a lot of love. We have this relationship with each other that extends beyond just the professional landscape. That said, specifically, I teach both levels now, undergraduate level and the graduate level. And the thing about aging is there's no one discipline really. You know, like if you're in a psychology department, everything is psychology. If you're in a sociology department, everything is sociology. But in gerontology, if you like many different things, which is basically what makes us human, different parts, right? We're the sum of different parts. I teach things like psychology, sociology, policy, all related to aging. So in that sense, it's really great for people who know that or who don't like to be limited to one topic. I mean, you can tell as well from my background. I studied mathematics, I did digital storytelling, and suddenly I'm in gerontology. I don't like to be put in one specific box. But gerontology, that box, I don't mind being put in because it enables me it gives me the exposure to different things, different perspectives, different angles of looking at things. And all these are very critical or important tools in managing not only my clients, the older adults that I work with, but also myself. Because I've learned so much about growing older. It's certainly improved my relationship with my mother, for example. I don't know about you, but mother-daughter relationships sometimes can be pretty tense. But since I've exposed myself to studying, the psychology of aging, understanding the systems, the sociology, the social structures of aging that may shape my mother, how she has aged into the 76-year-old woman that she is today, understanding or knowing, being aware of these things have helped me tremendously in managing our relationship. So I like to think that at this age, in my 40s now, I finally can live with my mother if I had to. And I personally really enjoyed it because I was just home during the summer and I had a really good time with my mom. We spent like two plus months together, and we didn't argue very much at all. So to me, that is a big success. So yeah. If you have more questions about gerontology, the program specifically, be it undergraduate, graduate, or even PhD level, please feel free to email me at this email address that you should be able to see on the screen right here. I'm happy to answer any questions that I am able to about the program. Of course, specific admissions questions, you would probably have to direct to Mr. Stephen Stump, I think is how you pronounce your last name. Sorry if I'm wrong. But any other questions about the program, what it is that you can maybe do while you're in the program or after you leave the program, I'm happy to share with you whatever it is that I know, be it from a personal point of view or even, from talking to all my students at both undergraduate and graduate level. So yeah.
Okay, thank you. And now, because of our limited time, so let's say the last question. And our last question is, how can I apply for the gerontology and can be the student of you? Thank you.
Okay, I think this is a question for Mr. Stephen Stubbs.
Yes, if you have any questions about applying to any of our programs, you can take some of Dr. Ho's classes in our master's programs. You could potentially work in the lab that she mentioned, Dr. Susan Guidanos, in our PhD programs. Feel free to go to our website, which is gero.usc.edu, and you can find the application information there. You can also reach out to myself or May via email, and we can send you the relevant information that way. Or you can also reach out to May on WeChat. Her WeChat is USC MAYNG, and she can direct you to the appropriate URLs. And we're also happy to set up individual appointments via Zoom or in person to answer any questions about which program's the best fit for you, or discuss specific questions about the application process.
Yeah, and may I just add to that, if you have anything you'd like to talk about aside from email, I'm happy to chat with you over Zoom as well. Time difference is a non-issue to me because I'm usually connected to Asia somehow anyway, since my family is home. I'm very happy to discuss the opportunities, especially as an international student. A plug for American education. If I was home, I probably wouldn't have had the same kind of opportunities that USC and especially the Leonard Davios School of Gerontology has afforded. So very simple example. For one, it's an education within a very large city, so you have access to many different types of older adults. One of the programs I was lucky to be participating in as well was actually living in a retirement community. So I worked with older adults, I lived with them, I ate with them, and that's why I learned so much about growing older, so much good wisdom that my friends shared with me. And in fact, to this day, I'm still very good friends with them. They are like in the 70s, the 80s, 90s. I even know a lady who's like 104 years old. So it's been an amazing experience for me, and definitely one I would strongly encourage you to at least explore, if not pursue wholeheartedly.
Okay, thank you. Thank you for your wonderful speech, and thank you for your time. And also thank you for our May and Stephen. And for the last part of today's webinar, could our guest speakers please give some advice or suggestion to our potential students and the audience who are interested in our graduate programs? Thank you.
I'm going to steal this pearl of wisdom from the late Steve Jobs. Stay hungry, stay foolish. Always remain curious because one, life is short. Two, life is not constant. The only thing constant in life is change. So you always have to equip yourself with as many tools as possible to adapt quickly to these changes that we are definitely going to experience throughout life. So stay hungry, stay foolish, be curious, and apply to Leonard Davis School of Gerontology.
I think if you have any questions, if you have any doubts about how a gerontology degree can help you with your career, we have programs that focus on many other aspects of the field as well: nutrition, dietetics, medicine, some of the other disciplines that Dr. Ho mentioned, such as sociology, public policy, administration, and management. And we have PhDs that also focus on biology, stem cells, regenerative properties, biomedical sciences. So we are all encompassing in our study, and we're here to answer any questions of how gerontology can fit in with your interests, your goals, whether they be academic or career.
我今天很高兴你们来参加这个活动，谢谢你们，谢谢。
Thank you again for our Dr. Deborah and May and Steven. Thank you very much. Thank you.